Medical students often memorize nephrotic syndrome, nephritic syndrome, acute renal failure, and chronic renal failure as distinct isolated conditions on separate flashcards. When you learn the pathology this way, patients presenting with overlapping symptoms inevitably cause diagnostic confusion. The rigid boundaries of rote memorization break down on the clinic floor. These syndromes are actually sequential stages of physical damage occurring in the exact same anatomical structure. If we look at this animated timeline, we can plot these four conditions on a single axis of progressive physical degradation. The structure degrading along this timeline is the glomerulus, the microscopic filtration barrier inside the kidney. By tracking how this barrier physically breaks down step by step, we can replace the memorization of disconnected symptoms with pure structural intuition. A healthy glomerular filtration barrier operates with strict physical boundaries. It keeps essential blood components circulating inside the vessels, while allowing waste products to pass out into the urine. Here are the three layers of a healthy glomerular capillary: inner endothelial cells, the middle basement membrane, and outer podocytes. In stage 1, mild injury creates minor gaps, allowing small, uniform proteins to slip from the blood directly into the urine space. This leak of only specific, small proteins is called selective proteinuria. In stage 2, the physical injury worsens. Gaps in the basement membrane and podocytes widen significantly. Losing size restriction, these wider gaps allow various large proteins to escape. This loss of size restriction defines the shift to non-selective proteinuria. During stages 1 and 2, the physical structure is compromised, but it remains intact. These permeability defects are the earliest clinical warning signs on the continuum. In stage 3, the physical architecture of the barrier suffers massive, widespread damage, stopping just short of a total rupture. Looking at the degraded capillary wall here, there is a massive, continuous outflow of albumin escaping the blood compartment. The sheer volume of this leakage is classified as heavy proteinuria. Losing this much protein creates an immediate vascular consequence, a severe drop in blood protein levels, known as hypoproteinemia. This flowchart tracks the chain reaction. Heavy proteinuria causes hypoproteinemia, which eliminates the oncotic pressure required to hold fluid inside the blood vessels. Without that pressure holding the fluid in place, it leaks out of the vascular system and pools into the surrounding body tissues. This resulting total body swelling is known clinically as generalized edema. This specific systemic cascade, massive structural leakage driving fluid shifts and edema, is the precise physiological definition of nephrotic syndrome. Stage 4 marks a critical escalation from severe permeability defects to the outright physical tearing of the capillary wall. The capillary wall physically tears open. Red blood cells, normally too large, escape through the ruptures. Forcing through the jagged tear, they warp and suffer permanent deformity. In the tubules, these damaged cells clump into rigid, cylindrical RBC casts. Under a microscope, these casts confirm the clinical presentation: hematuria, or blood in the urine, combined with ongoing proteinuria. This specific combination of symptoms is called nephritic syndrome. Nephritic syndrome represents the definitive diagnostic proof of a ruptured, bleeding glomerular barrier. Red blood cells are large, but they are not the only, nor the most dangerous, elements escaping through the ruptured barrier in stage 4. Strand-like fibrin molecules also force their way through the capillary tear, spilling outward into the lumen space. Fibrin acts as a chemical trigger, hyperstimulating local growth factors. In response, epithelial and endothelial cells rapidly multiply into a chaotic, expanding cellular mass. This dense mass forms a crescent shape, physically crushing the fragile capillary tuft inside. This mass is defined as a crescent, and its formation is the hallmark of rapidly progressive glomerulonephritis. By physically strangling the glomerulus, the crescent instantly halts filtration, causing the clinical emergency known as acute renal failure. If we move the timeline forward, we have to ask what happens to the kidney if the inflammatory damage from nephrotic or nephritic syndromes is left unresolved for long durations. In this wide view of the choked glomerulus, inflammatory cells flood the site of the chronic damage, releasing a continuous stream of signal particles. These chemical signals activate local fibroblasts in the tissue. The activated fibroblasts respond by laying down rigid, non-functional scar tissue over whatever remains of the original anatomy. This irreversible fibrotic replacement of the glomerulus is called hyalinization. Once hyalinization occurs, the filtering capacity of that specific glomerulus is permanently lost. Chronic renal failure represents the final stage of this continuum, the total hyalinization of a glomerulus following prolonged, unresolved physical damage.